طبعا استاذ دكتور ايهاب عبد الحميد، استاذ طب الاطفال وسكر وغدد الاطفال في جامعه الزقازيق. اتفضل يا فندم.
السلام عليكم. طبعا انا بشكر الاستاذ دكتور سامح توفيق على الدعوه الكريمه، وبشكر الشير بيرسونز ماي كوليجز. I will start my case. Ahmed Ali, the non-diabetic, 15 years old, from Zagazig, second kid in his family. The condition started 6 months ago with history of swelling in the right knee, with hotness, redness, and limitation of movement. All these are for arthritis. The condition was associated with high fever, uncontrolled hyperglycemia. The parent asked medical advice, and the patient was directed to ICU. The patient admitted for the case of DKA, and synovial fluid aspiration and analysis was done, and the condition was diagnosed as right knee joint septic arthritis. DKA was managed, and the patient was shifted to sub-Q insulin. The patient was treated with empirical and culture-based from the aspirate, and for 1.5 months, and 3 times joint open drainage, and the condition was improved. Baseline investigation shows increased serum creatinine, which was 1.8 milligram per DL. After complete resolution, skin grafting from the left side was successfully done, and the patient was discharged. And this is his picture. After 1 month, patient experienced eye puffiness, face edema, and the condition progressively increased. After 4 days, the patient has 1 attack of tonic-clonic convulsion and persist for 10 minutes and stopped spontaneously. Patient was admitted again in the ICU. And he was diagnosed as uremic encephalopathy based on creatinine level was 3.5 milligram per DL, and hemodialysis was done in the PICU daily for 3 days till the patient improved and serum creatinine decreased to 2 milligram per DL. Then the patient was discharged on torsuretic, 10 milligram daily. After 2 months, the right knee showing recurrence of the joint swelling, which was progressively increased, associated again with severe pain and inability to walk, and the patient readmitted again to the ICU. Unfortunately, trials for medical treatment failed, and the above knee amputation was done. The surgical wound developed septic infection with copious purulent discharge. Surgical open drainage was done after 20 days, which followed by gradual improvement. During patient admission, he developed again eye puffiness, face edema, and abdominal enlargement, which was progressively increased. His blood pressure was 180/100, and his investigation showed the following. Serum creat was 2.25, and urea nitrogen was 35.6, and electrolytes, sodium was low, and potassium was 4.2, calcium 7.8, and serum phosphorus 5.2, and serum magnesium was 1.47. And again, urine albumin creat ratio was sky high, 8,500, and serum albumin was 2 milligram per DL, and ALT and AST were normal. Lipid profile showing picture of dyslipidemia with LDL 180 milligram per DL. CBCO apart from normocytic normochromic anemia, and hemoglobin A1C was 12.5. Screening of other autoimmune disorders is still pending. Acidic fluid analysis, because he has abdominal enlargement, and sonar show septic peritonitis with glucose 330 milligram per DL, and total protein 1,809 milligram per DL. Picture of septic peritonitis. Patient was treated with triple therapy with cefotriaxone, ciprofloxacin, and metronidazole with gradual improvement. Blood pressure is controlled on methyl dopa and rimipril 125 milligram tritase, which is TSOH for proteinuria, and the patient still admitted there. Chest examination, bilateral diminished air entry, bilateral fine basal crypts, and this is X-ray. Of course, he's not centralized, but showing cardiomegaly. And fundus examination, moderate non-proliferative diabetic retinopathy with exudate and microaneurysm, and proliferative retinopathy. Echocardiography was done, mild to moderate global dyskinesia, ejection fraction was 50%, mild left ventricular dilatation, picture of toxic myocarditis. past history, who was diagnosed with type 1 diabetes at the age of 3 years. Patient was treated with mixed TARD for 10 years. Again, still some people are using mixed TARD for these patients, of course, and then shifted to basal bolus regimen. So if we put this patient in a differential diagnosis, is this CKD complicating type 1 diabetes as diabetic nephropathy, but he has a nephrotic range, the urine albumin creatinine is sky high, or this nephrotic syndrome with diabetes association, or this systemic lupus erythematosus, or sepsis sepsis was due to poor control. Diabetes with nephrotic syndrome has an immunological base. Systemic lupus, unfortunately, we do autoimmune panel, and the only one result is ANA was positive, and still the others are pending, like antiphospholipid or anti-lupus anticoagulant and other autoimmune disorders for lupus. Again, avoid the message here is to avoid pre-mixed insulin in pediatric patients because still using mixed TARD, and this is how the diabetes causing recurrent infections. And these are some of the review of literature: septic microvascular arthritis in patient with diabetes, and silent septic arthritis again with case reports. And as there is sometimes lupus with type 1 leading to end-stage renal disease, a case report and review with literature, and lupus nephritis in a child with type 1 diabetes mellitus. And if we, again, type 1 diabetes with celiac, with systemic lupus and systemic scleroderma in 15 years old girl. And if there is anybody do autoimmune antibodies in type 1 diabetes, this is a paper, 2016. He found that antinuclear antibodies is found either in type 1 and also in type 2, about 16%. And so I don't know, now I still did get the diagnosis finalized, but can be nephrotic syndrome with diabetes, or can be lupus with diabetes, but the condition is still not yet resolved until now. And my take-home message: avoid premix insulin, respect the strict follow-up, always expect the worst, aggressive management, and again, we have to meticulous follow-up of type 1 diabetes for chronic complications, microvascular and macrovascular complications is very important, and also consider patients complete. And thank you very much.